Just to make sure we finish off, or there's a couple of people asked me at the break, so I want to just say one more time that the fact that that animal had a urine-specific gravity that, what's his name? What was the name of the dog? And he had 1.003 meant she couldn't have structural renal disease, and she also wasn't going to have a disorder that was modifying her nephrons so that they couldn't create that medullary hypertonicity because she could dilute that well. So it was antidiuretic hormone deficiency or primary polydipsia.
Can I just ask a question? When you say primary polydipsia, to me, I think psychogenic polydipsia. So therefore, I would think that liver would be ruled out.
Why?
Because isn't psychogenic behaviour?
So psychogenic is behavioural, and liver disease can produce interference with the nephron's ability to create medullary concentration. That would be not the reason in this dog, but liver disease can also produce behavioural changes.
Okay, well that's mine. And also I suppose corticosteroid shunt generally would come in with neurological anomalies, either be thinking or weight loss or something like that.
Okay, so it's important for everybody, I think, to say, let's do it in the problem-oriented approach. You're eating into my diabetes time, but that's okay. I love you and I want to get this part done, and I'll press on you to give me another 5 minutes somewhere. But here's the thing. If I have a behavioural abnormality, what system must be involved? And what's the next question? Is it primary or secondary? It can be primary because I have some structural change or I have functional intracranial disease. That would be, let's say, epilepsy or narcolepsy or something. Or it can be secondary to an outside, to a dysfunction of another body system that's interfering with cerebrocortical function, aka low blood glucose, low calcium, high calcium, or the various agents that are not removed in an animal that's got hepatic encephalopathy. So that animal had behavioural change, it had a CNS abnormality that was secondary to an extracranial abnormality, in this case, cortisystemic shunt. That's why it was drinking too much water.
So I mean, we talk about psychogenic polydipsia, I thought it was just like a dog that likes to drink water.
It is a dog that is drinking too much water because its brain is telling it to do so. And it could be behavioural, it could be because it likes to drink water because it's become enamoured with the idea of going to the water bowl and splashing it around and seeing it go everywhere. It could be all sorts of things. The point is, that's why it's doing it. Okay? Cool? Let's define diabetes mellitus. Just make sure that we're all on the same page. I mentioned very briefly earlier, clinically significant glucose intolerance. Well, I didn't mention that. So I'm going to suggest to you that diabetes mellitus is a disease, is an entity that we're talking about as practitioners. We're talking about clinically significant glucose intolerance. An animal comes into you with vomiting, depression, lethargy, inappetence for the last 3 days. You know that it's got no ketones in its urine. It's got a blood glucose of 22. How likely is that animal to have diabetes mellitus? Not likely at all. An animal comes into you, it's been hit by a car, has got some fractured skull, it's got a blood glucose of 54. How likely is that animal to have diabetes mellitus? Not at all. Head trauma can raise blood glucose significantly. I've got a very unwell cat for some reason, not eating, stressed, blood glucose of 19. Diabetes mellitus? No. So you can't define diabetes mellitus as hypoglycemia. You can't define diabetes mellitus as elevated insulin, because we don't measure it anyway. Diabetes mellitus is clinically significant glucose intolerance. And for us, clinically significant glucose intolerance means the clinical picture that we've seen from being educated from vet schools: polydipsia, polyuria, to some extent polyphagia, weight loss, increased appetite. And then the other clinical picture that's different, which is a diabetic ketoacidotic patient where I'm not eating very well, I'm unwell, I might be vomiting, but I've got to have significant ketonemia and ketonuria. All right, we're all on the same page. The illustration that we need to remember is that in the United States, for instance, at the moment in humans, as I referred to earlier, there are approximately 75 million diabetics. Humans, diabetics in the US, 75 million. But only about 15 to 20% of them know they're diabetics because they don't have any clinical signs, because in humans, diabetes is defined as someone with a fasting blood glucose of greater than 8.6 millimoles per litre. That's the American Diabetes Association definition. And they do that because if you've got a fasting blood glucose of greater than 8.6, it has a significant impact on all sorts of different epidemiology in terms of your increased likelihood of developing coronary vascular disease, microvascular disease, retinopathies, nephropathies, blah, 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 blah. If you go into hospital for anything, you're more likely to stay in there for longer, more likely to have secondary complications, etc., etc., etc. So it's a different entity than what we're dealing with. We're dealing with a patient who has enough clinical signs referable to the diabetes mellitus to be presented to us as a veterinarian. I just want to make sure we're all comfortable. Of course, that does bring in some interesting idiosyncrasies when someone says Aunt Maud has diabetes and they're managing her with diet. Why aren't I going to manage my dog that way? But we know that. And forgive me, but let's make sure we're all on the same page about how it develops. Dogs, different from cats, predominantly. Dogs, we have an animal that's got normal insulin secretion, normal islet activity, if you like, normal insulin sensitivity, and then something pop happens, and they acutely, over a period of usually 4, 6, 8 weeks, develop islet damage such that they don't have any longer insulin secreting capacity, and that results in diabetes mellitus. The fact that they don't have any insulin secreting capacity, the blood glucose goes up, will actually ultimately mean that they have decreased insulin sensitivity as a result of their diabetes mellitus, but that doesn't happen as part of the development of the process. And that's what we're going to expect to see, an absolute insulin deficiency in the vast majority of dogs that we encounter. The exception is going to be in the intact bitch, and we can talk about that if you like at the break. We also know on a number of different studies that there's a significant breed predisposition. So at the RVC now, we have approximately 7,000 diabetic dogs in our diabetic database, and this is the breed distribution in a Venn diagram, and you can see that the most prevalent purebred dog in our diabetic database is the Labrador. But the Labrador is not predisposed to developing diabetes because the odds ratio is close to 1 and odds ratio around 1 mean it's the same. So there's lots of Labradors in our diabetic dog database, but that's because there's lots of Labradors in the United Kingdom. You only have to go to Oxfordshire, drive around the Rugby, people in their Wellingtons. It's a trendy dog. On the other hand, Samoyeds are markedly overrepresented in our diabetic database compared to the normal dog population in the UK. Samoyeds are 22 times more likely to develop diabetes than a standard crossbred dog. Tibetan Terriers, Cairn Terriers, Yorkshire Terriers, Portuguese Water Spaniels, it doesn't really matter, does it? But what it sort of tells us as practitioners, well, the other thing is, and then some breeds in the UK anyway, are very unlikely to develop diabetes. You want to call them protected, but they're less likely to develop diabetes. We've got, in that 7,000, we have 2 boxes only. And one of those is a diabetic because he had a total pancreatectomy to treat an insulin-secreting tumour. So they just don't get it. And golden retrievers are really uncommon. German shepherds don't get diabetes. Lucky, isn't it? They're too busy getting gastrointestinal tract problems and all the other things. Golden retrievers in the UK are underrepresented in our diabetic database, but we're collecting diabetic dogs from the United States as well now, and they're overrepresented in the United States, even though they're golden retrievers. So US and UK golden retrievers aren't the same, and I can tell you they're also, for another reason, not the same as Australian golden retrievers, because when I was here, at least, Australian golden retrievers were by and large reasonably friendly dogs, and you sort of treated them almost like Labradors in terms of aggression. Don't go to UK and practice like that, or you get your face bitten off. Some of them are nice, but not all of them. So there's a breed predisposition, and for that's important in not so much in day-to-day practice, but it's important for us to understand that means there's probably some sort of genetic predisposition to developing the problem. So there's something in the gene makeup of those animals that makes them more likely. And that's interesting also. I think it's interesting when you overlay that, which is the incidence, not the prevalence. In other words, the frequency that diabetes is diagnosed in UK practices, general practices, through the year, months. And you can see that it's much more commonly diagnosed in the winter months, significantly more so. And that's fascinating also because that's exactly what happens with type 1 diabetes in people in the UK. So we have a disease that has a genetic predisposition and has a seasonal incidence.
Couldn't that just be that in winter the animals are outside and so they notice the signs of feeding you more than if in summer when the dogs are more likely to be out in the yard or walks out?
Well, I mean, that would be one explanation, except that we correct it for all other cases coming in through the practice. So not coming, you might say, the other people sometimes say there's more animals inside. There's more animals coming to the vet in the wintertime than in the summertime.
Oh, well, they're inside the people's houses, so people...
For 3 months, or 4 months. They'd be finished, wouldn't they? They'd be dead. 3 to 4 months. I mean, there's lots of potential explanations. I don't think it's the reason why kids are more frequently diagnosed, though, in the wintertime. So, listen, fantastic. Love to talk to you about it at lunchtime, but I've got a job I've got to get through. Some people are going to be pissed if we talk about why this might be happening. All it suggests to us is probably this is activated by some form of occult, probably viral infection that is otherwise not causing any problems at all, because we know there's more likelihood of developing viral infections in colder months of the year, or inside, or whatever it happens to be. But it's just there. That's the dog situation. What about the cat situation? Let's look at the cat situation. Diabetes mellitus in cats. On the left side, insulin resistance. On the right side, the islet activity. Abstract terms, but to be used, illustrated. Here's my normal cat, slightly grumpy, doesn't really want to be on the image. He has normal resistance. He has insulin secretion to match his normal resistance, and that insulin secretion is proportionate to his maximum islet secreting capacity. Here's cat 2. He, by any stretch of the imagination, is fat. What does that mean? That means, almost without exception, always, obesity produces insulin resistance. Always produces insulin resistance. To match the insulin resistance, he has to have upregulation of his insulin secreting capacity, and it's closer to his maximum insulin secreting capacity. That's it. That's it. Now I'm going to take cat 3. Cat 3 is also overweight and has insulin resistance, upregulation of his insulin secretion, and it's close to his islet activity, maximum islet activity. But cat 3 has some form of abnormality yet to be determined, which results in chronic overproduction of insulin, damaging his insulin secreting cells. So the overproduction of insulin damages the islets. The overproduction of insulin brought about by the insulin resistance. The insulin resistance per se is not harmful. But in the individual who can't cope with chronic overproduction of insulin as an appropriate adaptive response to that insulin resistance, causes islet damage. And as a result, look at the slide, as a result, he loses his insulin secreting capacity. And clearly he becomes a diabetic. Somewhere in that decline. Somewhere about here, probably, in this sort of abstract, when it gets to about there, now he's going to start becoming hypoglycemic. Everybody clear? So that's how cats develop diabetes mellitus. A combination of insulin resistance in a group of cats who can't cope with that insulin resistance and have islet damage or damage their islets trying to cope with the insulin resistance. The insulin resistance is not going to cause diabetes all of the time. In fact, it's funny how anthropomorphizing things happen. The only 3 major species where this occurs naturally are cats, people, because that's type 2 diabetes mellitus, and baboons. Anybody's ever been in equine practice, bound to have seen a laminitic pony? Laminitic ponies have got the most profound insulin resistance of virtually any disorder in the animal kingdom. They'll have insulin levels of 1,000, 1,200 microunits per mil, and a normal horse has got 8 to 25. 8 to 25, 1,000, 1,200. They are profoundly insulin resistant. Ask any equine practitioner how many diabetic laminitic ponies they've seen. Never seen. Why not? Because the horse doesn't have the yet to be determined, not completely understood situation where overproduction of insulin for a chronic period of time causes islet damage. They don't get diabetes. Just like dogs don't. That's a myth. Overweight dogs don't develop diabetes any more frequently than underweight dogs, because dogs don't have the defect. They can cope with overproduction of insulin for long periods of time. Cats can't. Some cats can't. Some people can't. And some baboons can't. Not all overweight people, significantly morbidly obese people, will develop diabetes. But all significantly and morbidly overweight people have got insulin resistance. The insulin resistance is a given. The development of diabetes depends on a concurrent defect in their insulin secreting capacity. But what we're dealing then with cats is a variably reversible insulin deficiency, depending on when we interrupt the process. And we'll come back at the end of the lecture to talk about variably reversible. And that's probably around 85% of our diabetic cats. The other 15% are more like dogs. Okay, that's the end of talking about the diabetes in terms of diagnosis, understanding what we're talking about. The rest of the whole time now I'm going to be talking about management effectively. Bless you. First and foremost, if we're thinking about management, we're dealing with a major interaction between the owner and the patient. And the data that we're collecting, remember I told you about not collecting from referral centres, but we're collecting from you guys. We're collecting in a range of different ways around the world. The data that we're getting from collecting this data, from this data, would suggest that around 10% of dogs and 15% of cats are euthanized at the time of diagnosis in general practices. This is data from the United Kingdom, North America, US, Canada, continental Europe and Australasia. 10% of dogs, 15% of cats are euthanized at the time of diagnosis. And within the first year, another 10 to 15% are euthanized because of a range of different things. 15 to 20%, I should say. So in other words, we've got a loss of around 30 to 35% of our diabetic patients within one year of diagnosing them. That's in 2017, that data. So I think by any stretch of the imagination, we'd have to say the veterinary profession is managing diabetic patients poorly. 35% are dead within a year. Completely manageable disease. The cause of the loss falls into two broad categories. What are they? Well, firstly, just look at this. Over 1,200 veterinarians suggest that 1 in 5 diabetics treatment stops. So this is an evaluation of veterinary practitioners, continental Europe and UK. Well, no, that same group, so also Australasia, a little bit from South Africa and continental Europe. And look at that group there. And this one even, with the exception of this one, although you have to worry about that one a bit, do you see what this all means? All of this stuff here is to do with the owner. Not to do with the patient in various ways. It's to do with the owner. When we line up and ask owners, what is it that they don't like about having a diabetic? Or what is it, how do they find diabetics? Is it okay? What's the problems? Slightly leading question. How many of the top 10 reasons that they have trouble with their diabetic patient, their diabetic pet, how many of those top 10 reasons that that community of diabetic owners gives us do you think relates to the animal? Out of the 10. 1. And it's rated number 9, and it's fear of hypoglycemia, which still means it's impacting on the owner. When we actually look at how frequently we get hypoglycemia, it's not that common. So we work them up. We, the veterinarians, work them up about the fear of hypoglycemia. And it was just interesting to know that cats in Canada and Australia and rural practices around the world are more likely to euthanize diabetic cats than metropolitan situations, and I guess that's not that surprising. Oh, and I'm not. This is one of the reasons I wanted to give this. Wanted Nick to give the lecture yesterday to talk to you about the EPIC study, because I think it's a really serious paradigm shift in how we manage heart failure. And I want to give this lecture today because I think it's really time. I really think it's time that we stopped doing some of the things that have been being suggested for such a long time, because you can't in 2018 think that the veterinary profession is doing a good job if we're unable to manage effectively a third of the diabetics within a year of the time. That's just embarrassing, isn't it? And it's all of us in the same boat. And maybe it's not your practice. I'm not suggesting for a nanosecond it's any individual. I'm just saying we're not hitting the right buttons here. And a component of it has to be about us focusing a bit more as a veterinary profession on quality of life. For the owners, for the animal, and to some extent for ourselves, but particularly for the owners and the animal. And what I think is a really serious issue is this whole idea of protocols. And I think we have to sort of stop thinking about protocols and start to think about principles. So, principle 1, wherever possible, correct the underlying causes and or factors that interfere with insulin's actions. Get them to lose weight, etc., etc. This is in your notes. Reduce the hypoglycemia, ideally to less than 15 millimoles, but minimising hypoglycemia, meaning probably we're going to use longer acting insulins, and reduce the hypoglycemic impact of the meals, using the most palatable food for the individual patient with the lowest glycemic index. They're the 3 principles. Always remembering this is a major interaction between the owner and the patient. As a result, flexibility is a key component to the success. Principles, not so much protocols. If you tell them that they have to give the insulin every 12 hours, and they have to give the insulin with the food, and they have to feed this much, and it has to be 55 grams, and they have to do that, and they have to do that. There's a group of people who will try and do that because they love their animal, and they'll bust the gut to do that for a while, and after a while, a bunch of them will say, you know what, this is all just too hard. But the vet said I had to do this. And they'll kill them. They don't want to, they'll be upset, it won't go well, all of that stuff. This is a major interaction between the owner and the patient, and that's going to mean that we'll have different situations, and therefore we need to be recognising we have different situations. Depending on the owner, it can be different priorities. I'm not quite sure how much time Malcolm will have in his hands after the next election, and this is not a political statement whatsoever. But at the moment, he's fairly busy. If you asked him to give his cat, diabetic cat, insulin at 7 and 7, be home by 7 to make sure he gets his insulin, be home and make sure he gets his food at 7 o'clock as well, or 7:30 or 8 o'clock or 8:30, he's going to say, I've got a country to run. He said, well, you're not doing very well at the moment, so you may as well just give yourself an excuse. I didn't say that. On the other hand, Maud and John have got a bit more time on their hands. They mightn't have as much money. But if we said to them, we think it might be better if you gave this insulin 3 times a day and checked the blood glucose, would that be a problem? That would be no problem at all in terms of their time. And different people, different priorities. And I'm probably preaching to the converted, but that's important. And you won't have a protocol that'll fit Malcolm and John and Maud. But you will have a set of principles that you can adapt for Malcolm and for John and Maud. Correct the underlying causes, make sure we manage the blood glucose within a reasonable band, and reduce the hypoglycemic impact of the meals. And where possible, feed them a relatively low carbohydrate index. And that absolutely does not mean they need to be fed a commercial pet food. And finally, bullet point 4 is wherever you can, utilise the nursing team. It's not rocket science, it happens in the humans as well. Utilise the nursing team. They're there, they're available, they've got more time, they're more cost efficient, and they do a better job of talking to the clients about their diabetic diary, their patient's diabetic diary, what they may or may not be able to do with food. Train them up to get them to be the lead for the practice with your diabetic clients. Don't you get involved unless things are really going wrong. We'll talk about underlying factors a little bit later on. Reducing the hypoglycemia and keeping on managing it. There's lots of insulins available. All right? Do you have Prozinc here? People say yes and then people say no. Protamine zinc insulin. You'll have it soon. But you all have CAN insulin, and you all have Glargine, and you all have Detamir, and you probably almost certainly have protamine zinc insulin. Well, I know you do. It's a human product. And you don't have it in a cascade here. So it is always, well, it's a number of different things in terms of which insulin. The reality is it probably doesn't make a lot of difference. I know that's going to upset some people in the audience because that's not what they've heard before. And I'll show you some data in a minute. In dogs, probably insulin zinc suspension, which is CAN insulin or Vetulin, or an isophane insulin are all probably still the best insulin as a starting insulin. And this slide is here because in the United States you can buy isophane insulin from Walmart for approximately 20% of the CAN insulin or vet insulin in the US. And so American practitioners sort of say, well, what about isophane? I said, knock yourself out, it's absolutely fine. Certainly, there's no way in the world that CAN insulin is 80% better than isophane insulin. And cost is a factor. Isophane and protamine zinc insulin, fairly similar profiles, certainly not enough to warrant not using them. If you can get isophane insulin cheaply, then for your dogs, then use it. Cats, it's a little more controversial. We've done a study now, this is one of the first studies we did, which compared CAN insulin with a protamine zinc insulin product, both of them U40 insulins, so 40 units per mil, and protamine zinc was clearly better than CAN insulin in terms of managing the diabetes. Okay, this was the diabetic clinical score, which I'll explain to you later, in terms of improvement in mean blood glucose, serum fructosamines. We saw significant differences in the protamine zinc treated cats versus the CAN insulin treated cats. These are cats that were randomly allocated and managed identically in our diabetic remission clinic at the RVC. But the other one is to just look at glargine, because I know people have been saying for a while from various different centres, but most of it coming from Jackie's group, is that glargine is better, is the best insulin for cats. And it produces higher levels of remission rates. And we'll talk about that hopefully at the end. But here's a study that looks at 50 cats, randomly allocated, 50 cats each group, to glargine or protamine zinc. And we put them on glargine or protamine zinc, though a similar, identical effect, and then we followed them for a variable period of time. And the headline story of this is, there's no difference. There is no difference between managing cats with protamine zinc insulin or glargine insulin. If you don't have protamine zinc, that's fine. Use glargine. Protamine zinc in our country, in UK at least, is significantly cheaper and is part of the cascade. And we did the study to find out whether or not it was okay. This study was sponsored by Boehringer Ingelheim, the people who make the protamine zinc insulin. But there was no difference in control, any criteria that we used. So, just to make sure, I don't think I have to say that in this country, but in Britain at least, still over a third of veterinarians are using insulin once daily in their cats, which is really not a good measure of success. We're not going to do that. We need to use it twice daily, at least. Don't be afraid to use it more frequently if that's where you find yourself. It's a major interaction between the owner and the animal. The insulin that you choose is up to you, but don't be under the impression that you have to use glargine in the cat, because it will unarguably improve your control, because it won't relative to protamine zinc. It probably will relative to CAN insulin. How do I start off treating my diabetic patient? Everybody's got a different protocol. I thought I'd share this one with you. It's worked for me for a long time, over 35 years. Most people suggest 0.25 to 0.5 units twice a day for a dog. I up it to half to 3/4 of a unit per kilo twice daily for a dog, because when you start an animal on insulin, they are automatically insulin resistant, because the high blood glucose lowers the glucose transport proteins, so the insulin won't work as well at the start as it will down in a week's time. Feed a standardised diet, given 12 hourly. Standardised doesn't mean commercial. Standardised doesn't mean particularly controlled. We'll talk about, doesn't mean a specific type of diet. We'll talk about diet in a minute. But a standardised diet, let's agree that it's going to be consistent each day. 12 hourly, I give it twice daily insulin, I give it a meal twice daily, and send the animal home as soon as possible. Having got my veterinary nursing team to illustrate, to demonstrate to them, and then have them perform for the veterinary nursing team the injection technique. And we reassess the patient in 3, 5, 7 days. The veterinary nursing team to remind the owners about injection technique Too many owners watch too many shows, like, I don't know what the medical show is in Australia these days, Holby City or something like that. ER, everybody wants to think they know, everybody thinks they know how to give an injection, and they probably do. But remember, tell them to keep their thumb on the barrel. Keep the thumb away from the plunger. Don't let them inject under the skin with their thumb on the plunger, otherwise you get variable insulin delivery. Thumb on the barrel, glabrous side, either side. Don't get them doing the neck. The neck's a more variable absorption area. Either side of the skin in the relatively hairless areas, left, right, left, right, left, right, whatever they get in the habit of doing. Thumb on the plunger, and then once it's under the skin, then inject it. Never sterilise the skin, because if it's wet after they've injected, they know they've missed, and they can come back and say, I need some advice about injecting because I must be missing because I've got a little wet spot where I injected. And when we're talking about 0.1 of a mil or 0.05 of a mil, that's really important. And I'm embarrassed to sort of say that to you, or you can be irritated with me wasting your time, but so many times we have difficult managed diabetics, and it's around the owner's injection technique, etc., etc., etc. If you've got variably disabled owners, obviously the pens are going to help. You've got can insulin pens in this country. They work reasonably well. They're reasonably precise. You've got Lantus pens. You've got Detamir pens. You've got Protamine zinc pens. Use a pen if you want. A bit more expensive. Gets around some of the aversions. Twice daily. Whenever anyone says anything about, oh, can insulin's good because it doesn't produce antibodies in dogs, that's true, but it doesn't matter. There's been any number of studies that have shown that the level of antibodies has got nothing to do with, or in no way relates to the quality of diabetic control. Are you getting the picture about the nursing? Use the nurses where you can. Much more efficient. Reducing the hypoglycemic impact of the meals. When are we going to finish? 12:30, 12:35. Reducing the hypoglycemic impact of the meals. Let's just get this sorted. The caloric content that we're feeding the dog or the cat needs to be standardised. And the intake needs to be regulated to body weight. On this slide, I've got 60 to 80 kilocalories per kilogram body weight, which is perhaps too generous, but certainly no more than that. In the notes, I think what I've put down is 50 to 60. It's a guide. It's always a guide. If you started to tell them, well, this is how much food they have to get, and you weighed it out for them, it's a 10-kilo dog, you say they need 50 kilocalories per kilogram, that's 500 kilocalories, that's effectively 120 grams of dry food. Because remember, dry food, most dry food, commercial dry food, has around 400 kilocalories per 100 grams. Canned food has about 90. What do you think of sort of pork belly? What's the caloric content of pork belly? Fatty pork belly. About 300. Never underestimate the caloric density of dry food. But they're the numbers, you know, they've got all that stuff on the back of the pack, but this is easier if you do that. 50 to 60 kilocalories. But if you work it out and say it's 120 grams of dry food morning and night, and they say, oh, I never used to eat that much, you say, okay, well, I'll back off a little bit. Because we all know people, it's a guide, you know, we all know people who can have bacon, eggs, sausages, black pudding, 3 pieces of toast with marmalade, 2 cups of coffee with 3 spoons of sugar, and look like a stick. And someone else sniffs a cheese sandwich and puts on 5 kilos. So that sort of variability is inherent in the biological system. So it's a guide. We want to make sure that the composition is standardised though. Composition standardised carbohydrate content, fibre content, fat content. And there is a difference in terms of feeding between the species. Cats are relatively insensitive to insulin The suggestion is that's because they've been adapted for their obligate carnivore role. So they tend to have, in the wild, a low carbohydrate diet. Eating small rodents, the carbohydrate content is around 8 to 10% of a rodent. Protein content more like 50%. So their natural diet is high in protein, low in carbohydrate, and therefore quite a suitable diet to feed a diabetic cat, if that's what they like to eat. Or you can feed them a commercial equivalent. I absolutely suggest to you there is no difference in terms of the quality of their diabetic management. Others would say there are differences in other areas. It's not for me to comment on this particular time. What I can tell you is that normal cats can certainly adapt to variable levels of dietary carbohydrate. So there is no evidence to say that a cat fed a high carbohydrate diet is more likely to develop diabetes. None. Not that's appropriately controlled. But once they're a diabetic, we do, all other things being equalled, we will see improved control if they're fed a low carbohydrate diet rather than a high carbohydrate diet. So non-diabetic cats, open slather. Once they're a diabetic, it's better if we can feed them a high protein, low carbohydrate diet of whatever is most appropriate or attractive to you and the owner. Ideally, to match the insulin, it's better to feed them as set meals, but that doesn't always work, and so we then have to use or let them graze. But that's okay, let them graze. If we're using the longer acting insulins, such as protamine, zinc or glargine, in other words, not can insulin, that should be all right. Not ideal, but should be all right. This is the last study that anyone's done on it by Linda Fleeman, who, you know, most of you or many of you know is a diabetic expert, I think currently practicing still in Melbourne. And Linda did a great job of proving what numbers of us had been saying for a long time, but she had the time and effort to go out and do it and demonstrate that feeding a high carbohydrate diet or a diet high in fibre had no benefit in improving diabetic control in dogs. There was no need to give them RD or ID or whichever D you wanted to use. Feed them whatever is best for the owner and the dog. They've got enough to cope with in terms of the insulin they're giving, etc., etc. Just get them to feed whatever they think is going to be best for the dog in the longer term, but they're going to stick with it. They're not going to change it. Yeah.
You mentioned low glycemic index before, like I do have a low glycemic index. Doesn't WD have a good, I mean, isn't that one of the reasons they recommend it as a starting fix that it has a good glycemic index?
Yep. So I talk about mainly for cats in that situation.
I was saying.
Yeah. No, I should have elaborated that. I think the point is, if I can have a low glycemic index, it's probably not a bad idea, but don't stick to it as a protocol. It has to be a glycemic index. I want to try and make sure I minimise the impact of the meal on how fast the blood glucose goes up and goes down. Because what I'm trying to do is keep the blood glucose as stable as I can. Okay? And so this is a great question, and it's actually great timing, because here's the question. Here's the question. Is that optimal management? Don't answer. But let's remember the principles. Insulin lowers the blood glucose. Meals raise the blood glucose. Ideally, we want to match the opposing effects of the meal and the insulin to minimise the malutilisation, achieve relatively stable blood glucose. Everybody comfortable with that? Do you think that's a reasonable principle? That's one of the reasons why we talk about low glycemic index. So let's just put it in a graph, because I'm a visual sort of person. Effect of insulin on the blood glucose. I give insulin, the glucose goes down, comes back up again. Effect of the meal on the blood glucose. I give the meal, the glucose goes up, comes back down again. What I'm trying to do is match the effect of the insulin with the effect of the meal to keep the blood glucose about the same. And when I say I should say what we're trying to do. Right? Okay. Now I think it always helps a little bit in the middle of the day just to sort of do something slightly different. So I want you to all stand up again. I'm not going to get you to do anything physical this time. This time I'm helping you to stand up because I want you to take yourself back to, I'm looking at the average age of the audience, I want you to take yourself back about 20 years until when you were about 7. And I want you to remember that Sunday or that Saturday when you went on a picnic with some family, friends, grandma, by the river, by the beach, and you had lunch, and you couldn't wait to go swimming. And what did they say? You can't go swimming yet. Get a cramp. Didn't they say that? Yeah. So when were you allowed to go swimming? Okay, sit down now. Thank you. Why did they say that? Did you get a cramp because your stomach's got it empty? Now some of you, 7 was a little longer than 20 years ago, and you remember doing a barium meal. And you remember how fast did the barium get into the duodenum? How quickly after you gave the barium meal did the barium start appearing in the duodenum? Almost at once. 5 minutes. And the stomach was completely emptied within 40 minutes, 45 minutes, right? A little bit around the outside. But it's all in there getting absorbed. 40 minutes, an hour. When is insulin acting maximally? If I'm using can insulin or PZI or glargine? Answer, 3 to 4 hours. But your food was being absorbed almost straight after you eat it. And it's all in there getting absorbed, most of it, within an hour to an hour and a half. If you're trying to line up the effect of the insulin with the effect of the meal, and the insulin's acting maximally 3 to 4 hours after you've given it, and your meal is going to be being absorbed in the hour or so, hour and a half to 2 hours after you've given it, why would you ever give the meal and the insulin at the same time? To make it easier for the owners. And who says it's easier for the owners? So that's the only answer where it makes sense.
I thought, the argument said if they don't eat at the time insulin, you need to pass the insulin injection.
Why? Why would you set up a protocol to happen twice a day, 365 days a year, for the next 10 years, on the basis that on occasion, once, it won't eat? Oh no, that's what you were taught. I'm just asking you, but you're a cognitive, sensitive, intelligent human being. So some stupid git in the front of the lecture theatre says, this is what you do, and you go, oh, okay. Don't do that. Don't do that.
Because if you gave your insulin and your blood glucose dropped down to danger states, was the theory.
I know. So that's what you're going to do, right? So you're going to manage them all on the basis of a one-off event of hypoglycemia. It's not for me to tell you what to do. It is absolutely not for me to tell you what to do. It's for me to just ask the question of, do you think that's a great idea? How many times have you seen clinically significant hypoglycemia in your diabetic patients? Or let me ask you another question. Why did they not eat? Answer, probably because they're not very well. They're feeling sick. If they're feeling sick, they're going to be stressed. They're going to have an elevated cortisol. You know that. They're going to have insulin resistance. So they're not going to be as sensitive to hypoglycemia. I'm giving insulin twice a day. I'm giving it half the total daily dose of insulin. I'm giving it a meal. I want to try and match that up there. I'm never going to do it if I feed them at the same time. Make it easy on the owner, maybe. But on the other hand, tell me how it works, Mrs. Smith. What happens in your day? Well, I get up, fabulous. And then I make a cup of tea and I might have a shower, and you don't have to get deep and personal with them. In fact, you don't. You get the nurse to do that. And then I make some breakfast, and then I piss off, and I've done all of that in 40 minutes. Okay, so how about this? You get up in the morning, and the first thing you do is, or the second thing you do, is you inject the animal with insulin. And then you do your normal dick around stuff. You have your breakfast, and when you have your breakfast, you give him the breakfast, and then you leave. I could do that. But then someone says, oh no, but I like to give it with the insulin because that means they look forward to their insulin because they're going to have their meal. Answer to that question, give them a treat. Come on, have your injection. Here's the treat, injection. And then they say, well, I can't give it a treat because it's a diabetic. What are you talking about? You have a question? Did you have a question? No?
What about those cats?
Did you have a question? So I thought you could...
I suppose I'm thinking, I've got a patient of mine that's an extraordinarily picky eater, so obviously you could modify it. So if you've got a dog that's a consistent, or an animal that's a consistent eater, you do it that way.
Absolutely, and I'm not... Of course, this is not for every single patient. This is a point, really. It's not a protocol, it's a principle, it's a concept. And that's important for them to get over as well, is that, I want a little treat, give me insulin, doesn't eat. Oh my God, the world has collapsed. No, it's unlikely to be hypoglycemic. Leave the food there. If it's becoming hypoglycemia is an incredibly potent appetite stimulant. I can attest to that because during my PhD we had to have pituitary tests. Actually, turn that recording off there. No, it doesn't matter. But I know how hungry a rapidly falling blood glucose can make you. So you have to be pretty inappetent to not eat when you've got a low blood glucose. So just try it. I don't think this is a good idea. And you may well find that you'll improve the management. Clinical signs. So that's it on management. I don't want to make it more complicated than it is. Insulin, food. Try and mix them up at the right time so the insulin effect is matched by the meal effect. Probably best achieved by giving the meal about an hour to an hour and a half after, optimally, but that's not necessarily going to have to be the case. And of course, remind them if they miss a meal and an insulin injection, well, that's not the end of the world. So, I didn't get home, didn't do this, oh. So, okay, well, don't worry about it. They have an away day, They can miss a 12-hour insulin meal cycle. So monitoring now. Monitoring. Clinical signs.
Dave,
So,
what do you do for those cats that just like to nibble and graze on their food so they won't eat their allocated caloric intake that you give it?
so they nibble on it through the day.
Through the day.
Yeah, well, that's what it's going to be, Peter. So that I make sure that those guys are on protamine, zinc or glargine. But I don't really think detamir is the insulin for you to use as an exchange for the others, because detamir is actually in a very different way. It circulates in the outbound albumin. You need less detamir than any other insulin. So it's the one that you don't swap around and expect the dose rates to be roughly the same. So the insulins you're dealing with in the cat usually are going to be either glargine or PZI, or if it's John and Maud and they're at home a lot and the cat likes to grave all the time, then we certainly have a number of our cats, those people own those cats and their cat just eats a little bit all the way through the day, but they're quite happy to give the cat 3 injections or 4 injections a day, and that's what they do then too, of shorter acting insulin.
about those cats that are sick, like we're talking about, that may not be eating that well? Maybe like a 22-year-old diabetic cat, diabetes, and every now and again she's got pancreatitis as well, so she gets a little bit of vomiting and diarrhea every now and again, and she just goes off the food. So she doesn't eat as well, so I do tell the owner with those periods to reduce her insulin by half.
Absolutely. Yeah. So, I mean, again, exactly. If she doesn't have a meal, so a chronic cat, possibly pancreatitis, has the odd day or 2 days or 3 days or 1 day, or it goes off its food, what am I going to do? Reduce its insulin by half. Presumably it's on 2 or 3 units twice a day, drop it down to 2, drop it down to 1. 1 unit twice a day, the cat's not likely to get ketoacidotic until it bounces back. So, you know the principles. I'm just trying to stress to you that we have a range of different components that we can call on. Monitoring glucose curves, clinical signs, glucose curves, using the glucose curve to give me an average daily blood glucose. Then home glucose monitoring, fructosamine and glycosylated hemoglobin. I wanted to cover those 4 bullet points under monitoring. And the first thing is that reminding ourselves this is an interaction between the owner and the pet, and you introduce the concept of the numbers and blood glucose to them. Make sure you're careful when you do that, because they may well start focusing on that when what you particularly want them to be mindful of, and some of them won't be interested in the numbers, but they will be interested in the clinical picture. And the clinical picture is what we want. And part of the problem with me standing up and saying the clinical picture is that you go, yeah, but what does that mean? And my clinical picture and how I assess it will be different for different animals, and for different for different to you, to each different vet who sees the patient, because I've got a multi-person practice. And so different people are seeing them, they ask different questions, they have a slightly different feel. We need something that can help us standardise the clinical performance, for want of a better word, of our diabetic management. So we developed this thing called the RVC Diabetic Clinical Score, which sounds a bit impressive, and it's not. It's just a really, really straightforward thing, because there were too many pitfalls, and you had to sort of do everything. So what we wanted to do was make sure that we did this in the light of clinical science, to avoid all of these things, interperson variation, variable variations in the way people ask and answered questions, etc., etc., etc. So the Diabetic Clinical Score, validated and standardised it, published it, and it's a guide, really. And that's it. It's unintended weight loss, polydipsia and polyuria, appetite and attitude and activity, and a rating from 0 to 3. And you don't need to write it down, because I'll show you. It's described in your notes, but I'll show you where you can get it much more easily in a minute. And you get a score. And they can do it and bring it in for you, and then you know what that score is. And of course, the first time you do it, it's going to be moderately to significantly abstract. But the whole point is, it then gives you, over a period of time, an idea, or your nursing team, about how the animal's stable, how stable the animal is, or how unstable the animal is. And it's just an attempt for us to standardise and to somewhat objectivise this whole process. We developed a bit out of our quality of life questionnaires that we've been doing. What about fructosamine and glycosylated hemoglobin? Remember that both of these are simply measuring the amount of glucose that's irreversibly bound to a protein molecule. In the case of glycosylated hemoglobin, it's hemoglobin. Remember, the red cell membrane is completely permeable to glucose, so the intracellular glucose concentration of an erythrocyte is identical to the extracellular concentration, and that then will slowly bind to hemoglobin, and then you measure the glycosylated hemoglobin, and that will give you the average blood glucose for the last month, roughly. When it's fructosamine, exactly the same thing is happening, except we're not talking about hemoglobin, we're talking about albumin. And the binding occurs non-enzymatically. So therefore, the binding occurs at a rate that is dependent on the concentration of the albumin and the concentration of the glucose and how long they hang out together. So if the albumin concentration is stable and the albumin turnover is stable, then the fructosamine will be an indicator of the average blood glucose for the last roughly 2 weeks. If the albumin concentration is stable and if the albumin turnover is stable. When it's stable. And it's not going to be stable if I have, or it's not going to be comparable between animals or even in the same animal if there's a progression of glomerular disease, for instance, because then I'll have accelerated albumin turnover. If I have gut disease, if I have liver disease, it will change. If the gut disease, liver disease, or the leaking glomeruli don't change much, the fructosamine level, whatever it is, will stay roughly the same. But part of the problem with fructosamine is everybody says, oh, well, this is the normal range, and this animal is outside the normal range. Well, it might be, but that might be because the animal's got different turnover of its albumin. So you use it as an ongoing marker as opposed to necessarily straight up the first time. There's also potential problems with different labs and different estimates of fructosamine. So you've got to try and make sure you stick with one. And then there's home glucose monitoring. How many people use home glucose monitoring? So not as many. And what can we say about this? This has got it was a bit fatty for a while. It's a suitable process for most animals. In the original publication, 75%. The most recent one, that would now change, and we'd be talking more about 90% of patients. It's certainly not going to be for everybody. When it was reported originally, there was clearly marked differences. In about half the cases, you'd make a different decision about changing the insulin on the basis of a blood glucose curve performed at home versus a blood glucose curve performed in the hospital. I think the way to think of it is that it's complementary to fructosamine, and there are a range of different devices. The Alpha Track is the one I show here. That's not essential, but the Alpha Track's advantage is that it can be calibrated for cat and dog, and it only requires 25 microlitres of blood in there to evaluate it. People sometimes talk about the cost-benefit appraisal. If they're doing home glucose curves, then they're not bringing their animal in to be checked, and therefore I don't make as much money out of them. I think you can get around that to some extent by making sure that they bring their diaries in without necessarily their animal so that they can be compared. One of the things that's fabulous about home glucose monitoring is if the owner and the animal don't like coming to see you, particularly because the cat or the dog doesn't like to come to see you, then you have suddenly taken away a serious level of stress for the owner. I have a cat, my own personal cat, who is a lovely cat, but he is an absolute nightmare in the car. He hates it. He urinates, he defecates, he howls, he gets stressed as hell coming to the vet. If he was a diabetic and I had to take him to the vet every month, I'd kill him. No, seriously. Seriously. I'm just using it as an illustration. I'd kill him. And I love him a lot. But I wouldn't do it to him. So home glucose monitoring has lots of potential impact. Once upon a time it was meant to be, you had to find the vein and you had to do all of this sort of stuff. This is one of our long-term diabetics for different reasons I'll tell you about in a minute. And she's just getting a blood glucose. Lauren's one of our nurses and is very meticulous, but it is extraordinarily simple if you haven't seen it. Any 25 gauge needle, Lauren's just going to stab her ear anywhere. And they can be really, you can have the worst and nastiest cat in the hospital, and they're pretty cool at home, you know. And you just, anywhere on the pinner, just stab it. She moved out of the picture that's there, but it's really just a stab. This is a 15-year-old cat that's been a diabetic for 12 years, so. And that's the blood that we need, that's all we need.
Okay, go.
Just put it on there. That's it, goes like a beep, and that's it, done. And you'll see how poorly controlled it is. And you can go on the RBC Diabetic Remission Clinic website and have videos so the owners can see that and see how easy that's a better one than that one. See how easy it is if they're sort of exercised about the whole thing. You get the nursing team, of course, to explain to them and show them how to do it. One of those Alpha Tracks in the UK costs around 50 quid, and each of those little thingos is about 10p. I don't know what they are in Australia, but it's something. And for Malcolm, it's almost certainly not suitable. For John and Maud, knockout. What we're doing, though, is getting an estimate of a couple of samples for the reliability of the blood glucose curve. This was a sample I took, it's actually now 8 months ago, so I should do it again just to refresh it. But this is an animal that came in and we had 3 blood glucose curves. This one's done at home. So day 1, day 2, day 3. So you're not interested in the rises and falls over a period. What I want to know is what the average was. And the average of each of these 3 curves was within 10% of the standard deviation. This cat's going great. And the blood glucose range there was, I think it was a 17, I think. And this one down here was 4. So notice that bullet point there, comparing day 1 and day 2, 27% of situations in hospital are different. What's probably fair to say is that the greater variation in the blood glucose curves tends to happen with the well-controlled patients. The poorly controlled patients tend to be fairly consistently poorly controlled, so the glucose curves are more consistently not good, so you know you've got to do something. Continuous blood glucose monitoring started off being quite a schleck. We've been doing it for 17 years in the RVC. We sort of initially pioneered these, but now these are the go, and I don't know how many people are using Freestyle Libre. So a couple. And are you having any trouble with them? They're a bit fiddly to put in sometimes, aren't they? But other than that. So this is £150 for 2 sensors and a reader. The last time I checked, it's about $300, I think, for a sensor, 2 sensors and a reader. And what you're doing is effectively, the sensor looks a little bit like one of those Nespresso pods. You just pull it out and it's got a reader that looks like a mobile phone. There's the applicator. You put the pod into the applicator and then you basically insert them onto the animal's skin. The outside of the outside of the pod has got an adhesive, and the centerpiece here has got a little sensor that is placed subcutaneously. It's got glucose oxidase in it, and it'll give you a continuous once it's placed in there. We always sedate our patients, and then variably, depending on the way they are, we give them a little bandage. And then we read it. Bring it out of the box, press the button, calibrates over 60 minutes, and then they're ready to go. And we get a printout, and we'll get a printout for 2.5 weeks of a continuous blood glucose at home. So, and again, that can be used for management. You're not going to use that on all patients, but if it's not going well or you're puzzled and the owner's not keen on doing home glucose monitoring, think about the Freestyle Libre. It's a good return on investment, and you can get a very effective continuous blood glucose printout, whether it's a dog or a cat.
Do they just last for 2.5 weeks and not a permanent thing?
Pardon?
Are they a permanent thing, or do you just get the readout for 2.5 weeks?
No, they're not a permanent thing. You get a readout for around 2 weeks until the glucose oxidase in the sensor runs out, and then that stops. So it's the interstitial. Did I say it was measuring blood glucose? It's not. It's measuring interstitial glucose, which is similar to blood glucose. And the interstitial glucose is being metabolised by the glucose oxidase, and that metabolism effectively produces a current which is recorded by the sensor and recognised by the little reader. And as soon as you run out of the glucose oxidase, there's no more chemical reaction, so there's no more result. What we just published something last year looking at the quality of life impact. So the DIQOL score, which is our diabetic, effectively our quality of life impact for the owner around home glucose monitoring. And it was interesting what we found with this, which is that in essence the owners were happier. The reason they were happier mainly was because they were less worried about things going wrong. When we actually compared, they felt they were more in control. The improvement in the diabetic control of the patient was less convincing, and in fact wasn't significant. But they felt better. No. So, what is the optimum protocol? Well, I think that depends on you and the owner, but one of the things we've also developed is the PET app, the PET Diabetes app, through the benefit of the Rumba Foundation. So this is a diabetic management tool developed for pet owners that we've developed at the RVC, and it incorporates a variety of different components about the animal's diabetes, including the owner's objectivised clinical impressions, which is a diabetic clinical score, and the owner's feeling about the quality of life, blood glucose curves, urinalysis data, whatever they want really, well not whatever they want, but quite a bit, injection site reminder, a caloric counter that they can use to work out their diets. The pet owner shares the information with the vet nursing team at the practice, which makes them feel empowered, the owners, and to some extent the nursing team. We can actually download the data from this for our diabetic research, so we can actually start getting a better feel for what's working and what's not working. So that's the RVC Pet Diabetes app, and I hope you know me well enough to know I wouldn't be telling you that and then sort of somehow charging you for it or something. So this is completely free. We developed it with the Rumba Foundation. If you go on to if you've got an Android, you go onto Google Store. I don't know how you do there, but if you've got an iPhone, just go onto the App Store and type in Diabetes app or RVC Diabetes, and you'll see it there. You can download it, so you've got it, and you can show your owners, and then they've got it, and they can do it, and it just gives them a feeling then about how it's all going, and they can send it to you as a download, and you can talk to them and discuss it with you. But it's about trying to make sure that we've got some level of quantification for diabetic management. And that's the Facebook page where you can also show them. There's a whole lot of stuff, including showing them videos of home glucose monitoring, testimonials about what they've done with their diabetic and how to help. Because it's sort of about it's about the quality of life for the animal and the owner, and that's where I think we have to focus really. Is different cases, different requirements. It's essential we see improved clinical signs. I think probably fructosamine, if it works for you, once every 3 months, once every 4 months. Home glucose monitoring, as we've said, helps the owners in terms of their interpretation of quality of life, in terms of their comfort and potentially the quality of life of the patient. Continuous glucose monitoring is a realistic option. It's not that expensive. I think you'd agree with me to put a Freestyle Libre on and you've got 2 weeks worth of blood glucoses, and you can then look at it and discuss it with them as to what may or may not be the best arrangement to improve. I put here urine glucose because people always talk about urine glucose in monitoring. It's generally, as I've said, is of limited value. On the other hand, of course, it's not of no value. You have a patient who's got a diabetic cat that's pretty well controlled, but they don't want to do home glucose monitoring. You say, okay, well, here's a couple of keto diasticks or urine dipsticks if you want. And on occasions, if it's get it to urinate in a litter tray, especially with beads, and make sure there's a dipstick in there so that you can have a look and see how much glucose is in the urine, so it can give you an indication of the glucosuria over a period of time. So it's because some owners just aren't going to be able to do home glucose monitoring, don't want to do the Libra, whatever they're going to do. But so you adapt the protocol. Therefore, you don't have a protocol. You have a set of principles.
Do you have to reimplant the sensor every 2 weeks? So
You're going to get 2 weeks out of it. So basically what we use it for is a 2-week block to have a look and see what's been going on. I'm not going to do it running continuously. So yeah, once it's worn out, you have to put a new one in. But we would do one on a patient, and then we might not do another one on that patient for 6 months or a year, or depending on how it's going.
they don't need to be taken out.
They can pull them on.
But the pods are kind of, you get a new pod for the next patient.
Yeah. The pod has a certain amount of glucose oxidase in it. Have a look at the website. It explains it all. And it stays on. Water, rain, they can do what they like. Swimming. It's for people.
You don't have to have it bandaged the whole time.
You don't have to have it bandaged. The reason that we bandage it to start with is because a number of them find it irritating and scratch at it and then pop, and you've got to do the whole thing all over again. That's a pain in the ass. Pardon? How heavy is it? It's really light. I wish I wouldn't say this, I'm going to touch wood. I haven't had anybody complain about it being inconvenient or a hassle yet.
We find they last about a week, and we don't sedate, so depending on the animal, we just clip up.
And then put it in.
Sometimes do the vet bond around the edge to try and keep it on longer.
Okay, fabulous.
And the client brings it themselves, and we just...
You only reckon you only get a week out?
Well, she says it only stays on a week.
Okay.
So maybe we should be bandaging, but the dog's happy without it, and we do it.
To be honest, I think, if you've got a week of continuous blood glucose printouts on an animal, the second week's not necessarily going to be all that much valuable to you. The thing is, you get an amazing amount of data, and it does give you, therefore, something that you can talk to them about, and they're comfortable, and as I said, they're engaged.
Do you worry about too much about the keto sticks for looking for ketonuria as well, or?
If I'm going to get them to put in the urine, we still have keto diastics in the UK. I presume you still have them here. So that would be my ideal. So because it means also then they can say, I've got it's got a little bit of ketones in it. You say, actually I might want to see them then. Yeah, I think it's really helpful. And of course that also helps with the owners who can't smell ketones. But some owners, just like, there's a bunch of us can and a bunch of us can't smell ketones.
Is there a particular, for the freestyle area, is there a particular spot that's better to put the pod on?
I can't answer. We always tend to put them around the middle of the sort of the lower cervical area dorsal. Where do you put yours?
Same.
Yeah. When you look at the pictures of the people, they're usually wearing them on their lateral upper arm. Okay. And the other thing to remind is that there's really you just can't justify early blood glucose monitoring when you're sort of starting them off, because they're going to change because they've got insulin resistance because they've been hypoglycemic for a while. Make sure we use the nursing team's calendar. Maybe there's a God above. I sort of wanted to. And all I ever learned from love was how to shoot at someone who loves you young. It's not a cry you can hear at night. It's not somebody who's seen the light. It's the cold and it's a broken hallelujah. Nationality was he? It was the only country that never won a gold medal when they hosted the Olympics. Canada. What was the question? Hugh walks in. I was thinking we're not doing it. So, twice daily insulin whenever possible, and ideally after exercise. 2 meals roughly 12 hours apart, ideally an hour after the injection. Dietary manipulation, consistent caloric intake, low carbohydrate diets in cats or high protein diets, however you achieve that, whether it's commercial food or chicken wings or rodents or whatever it happens to be. Monitoring with home blood glucose curves are probably going to be advantageous in a range of different ways. And remember, in cats this is a dynamic problem, so closer monitoring may be needed. And if control isn't readily achieved, we go looking for other diseases. And in the last 2 or 3 minutes, because I'm not going to do the rest of the lecture, I don't have time, but I want to say 2 things to you. Firstly, actually, I do have another 7 minutes, don't I? So I'll do 2 things that are important. Except it won't let me do it. Quick study that we did in the UK, now published 2016, but just as a reminder. When we're thinking about insulin not working properly, the common causes, upper urinary tract infections. We talked about it before. Upper urinary tract infections, clinical sign, polydipsia and polyuria. If I have an upper urinary tract infection, I quite frequently will not have any abnormalities on my microurine. My urine sediment will not be abnormal. 38% of diabetics, when we look, have got urinary tract infections, upper urinary tract infections, which can interfere with diabetic control. If it's not being well controlled, do a urine culture collected by cystocentesis. That number goes up to over 57% if the diabetic has also got hyperadrenocorticism. The vast majority of them have urinary tract infections. The majority of them have urinary tract infections. That's why when we were talking this morning and I said about taking the water away if the dog's drinking too much when it's on pred, before you do that, do a urine culture to make sure it doesn't have a urinary tract infection, because that, of course, as we said, is one of the reasons why the tubules can't concentrate the urine without destroying them. It doesn't destroy them, it doesn't produce structural change. So urinary tract infections, we've already talked, well, you mentioned about pancreatitis in cats can be a cause of variable insulin resistance. We're not going to miss it in the dog because it's such an overt clinical sign. It's a much more subtle disease in the cat. And then that leaves us with hyperadrenocorticism and acromegaly as the other 2 diseases that we need to think about. Jodie's going to talk about hyperadrenocorticism after lunch in a range of different scenarios, and we might do a case where we manage hyperadrenocorticism and diabetes tomorrow. Acromegaly has been a disease that people don't think about. When we first went to the United Kingdom, I was looking for something completely different, looking for levels of growth hormone in cats in diabetics for a different reason altogether. First 150 samples that were sent in to us by general practitioners in general practice in the United Kingdom, most of them from England though, we did serum IGF-1 levels. That's the hormone that's produced by the liver in response to growth hormone. And of the first 148, 54 of them had an IGF level of greater than 1,000, when the normal range in our assay was 30 to 400. We thought, wow. So we picked 1,000 and said, what's going on there? Most of them were markedly hyperglycemic and had elevated fructosamines. But a third of these cats had an IGF-1 level greater than 1,000. First off, thought the assay was dodgy, but no. We offered all of those cats free further workup. Come down, we'll do a CT, we'll do the whole 9 yards. abdominal ultrasound, have a look at your cat and see what's going on. 24 people took us up on the offer. And when we looked at them in more detail, 23 of the 24 were acromegalic. And the 24th one, which died 2 years later, we post-mortem, didn't die from a car accident. We post-mortemed it, and it had a microadenoma producing growth hormone. It was also an acromegalic. And the news and the important point for you guys is that less than 10% of them had the so-called phenotype, big head, spare teeth. They just looked like normal cats. Some of them had prognathism, but the vast majority, in fact, 90% of them, over 90% of them, just looked like normal cats. You couldn't tell them apart. They were just poorly controlled diabetics. We've continued to collect cats like that. What we've got now is a diabetic cat database, which is running at just a tick under 6,500. So just a bit behind the dogs. 6,500 diabetic cats in our database. And around 27% of them are acromegalic. A quarter. Pituitary mass. So what are we going to do? What are we going to do about our acromegaly? So aggressive insulin treatment, they won't go away. Aggressive insulin treatment, if the owners don't want to do anything, we have to just bear in mind that these cats are not going to be able to be controlled. Radiotherapy is disappointingly inconsistent. Paclitaxel injections are available, but they're very expensive. We've shown that they work, but they're very expensive. This is the option. And the reason I thought it was worth just briefly mentioning to you is two things. I'm not sure whether you've read the information, but we believe this is a disease that's as common. Most recently, University of California have done a study and demonstrated that around 22% of their diabetic cats that they're seeing in the California area are diabetic cats, are acromegalic as well. Now, there's some reasons why they might not be as prevalent here, because our cats are more outdoor in Australia than they are indoor in England, and we have reason to believe some of this is to do with inhalant and ingestion of fire retardant materials. But the point is, it's still something worth checking, especially if the cat isn't controlled well. And equally, especially because now you can do something about it as well, because you can do the hypophysectomies, or not you, but you can refer them to someone who can do the hypophysectomies. So before, there's the mass. After, comes out through the oral cavity. That's one of the cats. That cat's about 4 hours post-surgery. He's got 4 little sutures in his skull here, but that's just where he's sitting with the brace. That's where the brace is clamped to his skull to allow the surgeon to remove it. And once we take away their pituitary mass, we start them on twice daily insulin. We started them on glargine simply because the PZI, when we started this program, wasn't available. Generally, the insulin requirement is reduced within 24 to 48 hours. 85 to 90% of them are off insulin within a month. They've got to stay on thyroxine. They've got to stay on cortisone, not prednisolone, cortisone, and they have to stay on DDAVP. Or about a fifth of them have to stay on DDVAP. Most of them are off that by about a month. But they do have to stay on daily thyroxine and cortisone. But most of them are off insulin. They are effectively normal cats without an anterior pituitary. So we're not seeing this in dogs. And we potentially are seeing this in people. So our current running rate is, the RVC is 5. We had 5 die. They all died in the first 8 months. Done 60, actually we've done 72 now, but it doesn't matter. And the reason I thought it was worth mentioning is because firstly, you need to know about it. Secondly, but it doesn't help quite so much if you can't do anything about it. And this is absolutely not a plug for SASH, and I don't know whether they're actually doing it or not, but Patrick Kenny, who was the person who was our surgeon for 2 years who pioneered the surgery or who developed the surgery, is now working, he's working somewhere, a specialist practice in Sydney. So if you have one, you can send them to him. I don't know what they're charging. Is it SASH? And he'll be able to do it for you. They need to have the team around him because, in fact, the most expensive part of it is their insulin levels start coming down, and we keep them in ICU to check their insulin levels because we don't want to send them home and have a hypoglycemic, because often they go home not on insulin within a week. They also have hypertrophic cardiomyopathy with diastolic dysfunction, and so when we correct their acromegaly, their heart improves as well. So there's a couple of, maybe some of you have been reading in literature and from clinicians' brief and things that are talking about diabetic animals dying of, cats dying of heart disease more frequently. And for some reason, the authors of those papers haven't been reading some of the other papers that suggest that this is due to, very likely to be due to acromegaly. So, highly successful treatment. Not going to do it for everybody. You don't want the owners being risk averse, and you don't want the tumour to be too big. We get almost instantaneous normalisation of IGF-1, and there's a high chance of achieving diabetic remission, but you do need to have a skilled surgeon to make sure that happens. So that's all I have time for, really. Happy to answer any questions. No, I'm not. I don't have any time for questions. But I have time for a couple of questions. Other than that, we better have lunch. The last thing to say, I suppose, on the acromegaly thing is what I would suggest to you, because you probably screen for diseases with far lower prevalence than that. What I'd suggest to you is if you have a diabetic cat, you start it on insulin. When it comes back 4 or 5 days later, take a blood sample from it, separate the red cells from the serum, put it in the freezer, label it, and then if that cat starts to behave abnormally or seems to require more insulin, send it off for an IGF-1 level. It's easier to interpret if it's not on high levels of insulin. It must be on insulin for the IGF-1 assay to be validated, because the liver needs insulin in the system to make IGF-1 in response to growth hormone. So don't take the sample at the time you make the diagnosis. Take the sample once the animal's been on insulin for a little while. Okay? All right. Any questions?
There's a couple of things that I know of that recommend just doing spot pre-insulin PGs to determine change in insulin doses. Do you have any thoughts on that, or have you seen that done before, rather than glucose curves per se?
Yeah, I have seen it before. It wouldn't be my preferred option, because one sample of a blood glucose is so potentially variable to so many factors. That's my disquiet with it, really. I want to have a couple of samples. So if I hope I gave you the idea about the curve, what I'm interested in is getting 2 or 3 samples over a window that works for the owner, and then that gives me an average. If I think the time when people say check the blood glucose before I give the insulin is when you're trying to wean them off insulin, and you're thinking I'm declining the dose. How high is the blood glucose immediately before I give the next insulin injection? And some people say if it's less than 10, then I'll continue to decrease my blood glucose dose. I didn't show you any slides about remission. But I just may as well show you this one. So this is, we get told about a lot of different things about what remission rate we should expect. The answer is when people have told you 100% or 85%, that's from the literature, it's from the Journal of Feline Medicine and Surgery, it's from a couple of authors, it's actually pretty much exclusively from University of Queensland authors. And one of the things that's problematic with those papers, in my interpretation, is what they tell you is 80% remission of the animals that finished the study. not of the animals that started the study. The animals that started the study, from the animals that started the study, then the remission rates are around 25 to 35%. So which is what we tend to see in many of the other publications. Okay? So that's important. And then when you look at this, sorry. So this is just a graph showing you how the insulin goes down in response to insulin resistance, and then it can come back up again, right? These guys here, it doesn't change, but these animals are overproducing insulin and damaging their islets, and then we give them insulin and it comes back again. And someone will show you a graph which is those averages like that. But you want to know what the individuals are, because you're veterinarians dealing with individual animals. What's the individual look like? There they are.